Hello, welcome. I'm Dr. Tony Magliocco, the Cancer Informant. Today's episode of the Cancer Informant will be focusing on esophageal and gastric cancer. Gastric cancer is a relatively common cancer. It actually decreased in incidence since the early part of the 20th century. And dramatic decrease in the incidence of gastric cancer is thought to be attributable to the widespread introduction of refrigeration. However, there are still many risk factors for the development of gastric and esophageal cancer. Some of the risk factors include having gastric reflux disease and something called Barrett's esophagus. Other risk factors include smoking, alcohol, diabetes, and exposure to other types of toxins. In addition, there are certain familial disorders that can predispose to gastric cancer. These include inherited genes and genes such as E-cadherin and familial E-cadherin deficiency and mutation conditions. And other types of inherited factor genes may also predispose to gastric cancer. Now, if we talk about some of the key risk factors, one that we did mention is gastric reflux. Gastric reflux is actually quite common. It's thought as many as 30 million Americans may suffer from gastric reflux. So this is commonly known as heartburn. This is where you feel stomach acid coming up, maybe when you lie down or when you burp, where you may find a burning sensation in the bottom part of your esophagus or in the stomach area. So this can be a clue of an underlying reflux condition. When reflux is chronic, this can lead to inflammation of the esophagus and scarring. And if this persists for a long period of time, this inflammatory change can become what's called neoplastic, dysplastic, and actually turn into cancer. Now, it's particularly problematic because cancers of the lower esophagus tend to be discovered when they have already spread. There's a lot of interest in detecting these cancers at an earlier treatable stage. If a patient does have a suspicion of gastric reflux or Barrett's esophagus, often they're placed on a surveillance program where the esophagus is examined by endoscopy and biopsies to determine if there is any evidence of what's called dysplasia. So Barrett's esophagus is a benign condition where the normal lining of the esophagus is replaced with an abnormal but benign change. But with persistence, these benign cells can actually transform into pre-cancer and then turn into outright cancer, which can invade and spread. So the goal is to intervene in that process and remove these pre-cancer cells before they can do any harm. So this is the challenge of Barrett's esophagus. Now, one of the problems, like I said, it is quite common. So this means that a lot of people have to undergo endoscopy and evaluation. And sometimes this test or this procedure may miss early cancers and cancers can still arise. That is a problematic area. Now, gastric cancer also occurs similarly, can occur in the setting of gastric ulcer, where a person has a chronic inflammation of the esophagus and of the stomach, which can arise to gastric cancer or a malignant ulcer. Some of the predisposing factors to gastric ulcer are chronic gastritis. Sometimes there's a bacteria that causes this called Helicobacter pylori, that can lead to chronic inflammation and increased risk of gastric cancer. Treating these conditions of reflux and gastritis can definitely decrease the risk of developing gastric and esophageal cancer. Now, how are these cancers screened for? These cancers can be particularly problematic for symptoms and screening. Generally, the symptoms can be the heartburn, the pain. There could be bleeding, vomiting, blood in the vomit. There could be obstruction where a patient has difficulty swallowing, have nausea and vomiting, and so on. So these are common symptoms of esophageal and gastric cancer and are certainly cause for concern if these are persistent. The good news is that they can be easily investigated with scoping and treated at an early stage. There's also some interesting investigation about other ways to detect early cancer, and there's one approach where there are perhaps ability to swallow small cameras that can visualize the mucosa, and also swallowing things like gentle sponges that are on strings. So a patient can swallow these, and then these are pulled up, and they do a gentle biopsy of the stomach and the esophagus, and then cells can be sent to pathology for examination in early cancer, or pre-cancer can be detected and treated at that early stage. And then most importantly is the molecular characterization of the cancer, because many cancers in America do not get proper molecular classification and characterization. So evaluating whether HER2 is amplified, evaluating whether PD-L1 is expressed, and whether there are any other actionable mutations that might be present that could also be treatable. In addition, sometimes genetic information can be useful to determine if a patient is part of a cancer family syndrome. This information can be useful for the patient to determine if they're at risk of additional cancers and whether screening should be considered for those other cancers, and also if they've potentially passed the gene on to other members of their family, and whether those members of the family should consider more enhanced screening approaches for earlier detection of the cancer. So certainly genetic analysis is also quite important. Now, there are other options for diagnosis as well that may include liquid biopsy. So again, a blood test can reveal if there are abnormal cells in the blood, or also if there's fragments of abnormal DNA or even RNA in the blood, which can be helpful to determine if an underlying cancer is actually present. Many new technologies are now coming into the clinical lab and into clinical care, which makes it a lot easier for doctors to evaluate patients and a lot less painful and cumbersome for a patient to undergo a staging evaluation or an evaluation to determine if their cancer, what type of cancer they have, and if their particular cancer has certain targetable mutations, which makes them eligible for certain kinds of therapy, particularly targeted therapies or immune therapies. I like to tell all my patients about also the value of second opinion. So having a second opinion, an expert opinion, can be very useful to double check that a diagnosis of cancer is actually there, because in a surprising number of cases, there may be an error in the primary diagnosis. It's also important for staging in terms of, was the cancer completely excised? Were the lymph nodes involved, or were the margins clear? So again, a second set of eyes and an expert evaluation of this can be extremely useful. What are the treatment opportunities for gastric cancer? Generally, it can be treated at an early stage with something called surgical ablation. The mucosa can be burnt off or stripped through an endoscope if the cancer hasn't become invasive in the esophagus. Now, if the cancer has become invasive, then generally a more advanced procedure is required, where the esophagus or portion of it is removed with the stomach to try to remove the cancer and associated lymph nodes. If the cancer is confined to the esophagus and stomach, then surgical treatment may be all that's necessary. However, if the cancer has spread beyond the esophagus and stomach, then systematic treatment is then indicated. So cancers of the esophagus and stomach are frequently treated with chemotherapy, with radiotherapy, and now there are new treatment approaches that utilize targeted therapy. Interestingly, a proportion of gastric and esophagus cancers show amplification of the gene called HER2, the very same one that's involved in breast cancer. So it was discovered that in cancers that have overexpression or amplification of this gene, that they may respond very well to anti-targeted HER2 therapy. Generally now, in most cases of gastric and esophageal cancer, HER2 is tested for to determine if it's amplified or overexpressed. And this is an important finding for guiding therapy. Now, it's also been shown that immune therapy, immune checkpoint inhibitor, can also be quite effective. There are numerous treatments that can now use checkpoint inhibitors, and often they rely on evaluation of a protein called PD-L1. So if the tumor overexpresses PD-L1, this is measured with a stain by a pathologist. This patient could become eligible for a treatment with a checkpoint inhibitor, which can be quite effective in stopping the growth of metastatic gastric or esophageal cancer. There's also other drugs that are under investigation, other types of targeted therapies, because certain genes may become amplified, or fusions. For example, microsatellite instability might occur. You might find AMTRAC fusions, KRAS activating mutations, and so on. So there are many new emerging therapeutics that potentially can be used in the setting of esophageal and gastric cancer. Like all cancers, it's important that the diagnosis be made correctly. It's important that early detection be available and early treatment, which can remove precancer before it turns into an invasive cancer. And if it's early cancer, remove early cancer before it spreads to become more advanced cancer. Another area of consideration is clinical trials. And unfortunately, clinical trials are generally underutilized, which means there are more trials than there are patients available. Almost every patient could potentially qualify for a trial. getting onto a trial can be of extreme value for a patient because they will get access to an innovative new therapy. Trials are made to be as safe as possible, so they have safety committees that monitor them. They have teams of experts that design the trial to make sure that they're both safe and that when they work, that they will produce meaningful data, that practice changes can occur. Often there are multiple trials that can be available for a patient with any type of cancer, including esophageal and gastric cancers. Now, one of the key things about enrollment on a trial is that usually the cancer has to be correctly diagnosed. The patient needs to be relatively well so that they can withstand a new line of therapy. Now, if they're on a trial, often there's two arms. So on one arm, they get standard therapy. On the other, they get the novel therapy on a blinded trial. And on many of these studies, if it's shown that the new therapy appears to be effective, often a crossover is done where the patients on the control arm will actually be switched over ethically so they can also benefit from that new drug as well. So some patients may be concerned, saying, I don't want to go on a trial because I may not get the agent. But on many of the trial designs, the agent becomes available to other members of the study, even if they weren't on that arm at the beginning. That concludes today's discussion of gastric and esophageal cancer. In summary, like all cancers, early detection can make a big difference and, in fact, can lead to cure. For esophageal and gastric, some of the earliest signs are reflux and pain. It could be nausea and vomiting or difficulty swallowing. There are very effective treatments available for esophageal cancer. And when the cancer is appropriately molecularly examined, there are also targeted therapies and immune therapies now available for these cancers, which can be extremely effective. Also consider the opportunity of clinical trials, early access for patients, and also low cost. So clinical trials should always be a consideration for a patient who is failing conventional therapy, as long as they're well enough to go on a study or on a trial. I want to thank you for joining our episode today. I'm Tony Magliocco, the Cancer Informant. Please visit our website to hear other episodes and also leave us notes in terms of questions or suggestions for future episodes. Hope you have a wonderful day, and we look forward to connecting you again in the future.